Okay, let's get started now. So, in the last session, we have completed gastroenterology section, and in this session, we are going to start the genitourinary. Before proceeding further, does any of you have any questions, any doubt from the previous sessions, any questions which you want to discuss before proceeding?
No, ma'am.
Okay. Have you attempted those questions, the previous questions? Have you completed all the questions which I have shared?
Yes, ma'am. Yes, ma'am.
Okay. Also, just wanted to let you know from today onwards, in conjunction with the questions with the chapter specific question, I'm going to share the previous year mocks so that you can do the practices and clear your examination on time. So this will be not the final mock. You will get the final mock later, and these will be only the previous year mocks. Okay. So let's start with the surgery section. We are going to go through with the surgeries of the genitourinary section. In the genitourinary section, we are getting the codes for the procedures performed on the kidney, ureter, bladder, and urethra. So whenever there is a procedure performed on the kidney, directly on kidney, ureter, bladder, and urethra. In our manual, in our CPT manual, kidney referred as an nephro. So kidney is referred as an nephro. So whenever you see a word nephro in our manual, it will represent the kidney. And for bladder, the word used cyst. So whenever during a procedure you see cyst word, that means that represents bladder. Let me show you the brief of the urinary system. So in the urinary system, we have four major organs which will help our body to release the waste and filter out the blood. So waste are extra urea. So it will help us to release extra urea from the patient's body. So the first part of the urinary system is kidney. So kidneys are the bean-shaped organ. So bean-shaped, basically at this size of your fist. They are located near middle of the back, basically below the rib cage. We have two kidneys, left and the right kidney. Kidney will remove urea from the blood. So the major function of the urinary system is filtration of the blood. So blood. Okay. So kidney removes urea from the blood. We have the tiny filtering. These are the tiny filtering units, and these units are known as nephron. So nephron is the smallest unit of kidney that will help kidney to do the filtration, blood filtration with the help of nephron. Each nephron consists small capillaries that is also known as those capillaries known as glomerulus, and there is a small tube called as renal tubule. We have a very main component here, that is renal pelvis. Renal pelvis is a funnel which will help. Renal pelvis is a area which will behave as a funnel, and with the help of funnel, all wastage urea in the form of urine comes to the ureter, and through the ureter all waste get to the bladder. So this is a basic of the urinary system. So now let's start with the procedure. So first we will learn about the kidney procedures, then bladder, then cyst, and then urethra. So kidney section starts from the 500102 to 50593. Incision, excision, renal transplantation, introduction. Incision means whenever we are putting an incision into the organ or a structure. That may be due to the diagnostic purpose. Let me pull the codes also. So the suffix for incision is otomy. Suffix. Suffix. So the suffix for incision is otomy. So whenever we have made an incision into an organ or structure for a diagnostic purpose, or maybe to obtain the tissue, or to remove the foreign body, or remove the stone, or maybe to explore the organ, to place any drain to remove the fluid. So whenever we have to do the incision into the organ, we are going to call it as an nephrotomy. So otomy means incision and nephro means kidney. So the first code we have here, renal exploration. Renal exploration. Renal exploration means when the doctor mark the incision in the kidney to explore the nephrons or the renal cortex or the internal area of the kidney. So that is renal exploration. If the exploration has been performed for a particular specific procedure, for a therapeutic procedure, we are going to build the therapeutic procedure only. We are not going to build the renal exploration. We have to build this renal exploration when it has been performed for the diagnostic purpose. If it is performed for the diagnostic purpose only, then only we are going to build this. Otherwise, we have to use the therapeutic procedure code. Next code we have 50020, drainage of perirenal and the renal abscess. So the treatment for renal abscess can be open or percutaneous. This one is an open. We have a separate code for the percutaneous. Percutaneous means through skin. So in an open treatment for draining an abscess on the kidney or on surrounding renal tissue, that is a perinephral or nephric or perirenal area. So surrounding renal tissues, doctor did the small incision in the skin of the flank. So whenever doctor did this small incision on the skin of the flank. Just give me a sec. Okay. So the doctor did the small incision on the skin of the flank, muscle, fat, or fibrous membranes, which is overlying the kidney, and then cut the portion of the maybe rib to reach out to the kidney, 11th or 12th rib to reach out to the kidney, and then abscess cavity has been explored and indicated, and multiple drainage tubes, let's say Mellacott catheter, there is a Mellacott catheter, Depazer catheter, inserted to that incision. So the drain tubes and then sutured with the skin so that there is no further abscess accumulation or the pus accumulation. It will be drained at the same time when it has been created. Okay. Next, we have the nephrotomy. So this is a drainage of perirenal and renal abscess. I have already tell you that what doctor need to do, and in this procedure, doctor may place a drain tube and that will suture to the skin so that The first accumulation will not be there again. Now let's move further. Next section we have nephrotomy. Nephrotomy means a simple incision into the kidney for maybe for exploration or maybe for another procedure. So nephrotomy means simple incision. We have a one more word here, that is nephrostomy. Nephrostomy means creating an opening. Whenever you will see ostomy as in suffix, that will represent creating an opening. So whenever you have a ostomy word like nephrostomy or colostomy, that means there is an opening in that area. So first we have nephrostomy and nephrotomy with drainage. So doctor is creating an opening and then doing with the drainage, placing the drain tube so that there should not be accumulation of the pus. Then we have 50045 nephrotomy with the exploration. Now I have a one question for you. Can any one of you tell me the difference between 50045 and 50010? This is a renal exploration code 50010, and the next code we have 50045. Can any of you tell me the difference between these two? Any answers? Okay, let me tell you. So 50010 is for the diagnostic purpose only. Whenever doctor is doing renal exploration for the diagnostic purpose without any therapeutic intent, doctor does not know what is the conditions before doing the exploration, then we are going to do the 50010. But if doctor is making the incision to perform any particular therapeutic procedure, then we are going to use the 50045. Also, you have to remember one more thing. If we are doing major procedure, then we are not going to build the small procedures or the minor procedure like nephrotomy or the incision procedures separately. Let's say doctor is doing the kidney transplantation. So in the kidney transplantation, doctor need to make the incision in the kidney. In that case, we are not going to build the nephrotomy in conjunction with the kidney transplantation because that is included in the major procedure. So whenever you are going to build a small procedure, you have to make sure that this should not be included in other major procedures. Now let's move further. Next we have nephrolithotomy. Nephro means kidney, litho means stone, otomy means the incision into. So the nephrotomy means stones also can be removed by the open approach or the laparoscopy approach. So we have a different code for the different approaches also. So again, nephro means kidney. Litho, whenever you say this litho word, that will represent the stone. And this calculus word is also known as stone. So kidney stone. Calculus means accumulation of calcium. So that is a stone. So kidney basically approached through the flank incision. So like in this case, nephrolithotomy is there. So we have to approach the kidney through the flank incision. Again, that is we have to make the incision under the muscle and need to make the cut at the 12th rib. so that we can make the excess or approach the kidney wisely. And then kidney needs to be freed from the fatty tissues, surrounding fatty tissues, renal artery, and then we have to inject the drug so that kidneys blood supply won't damage. So for the even for the we are removing the stone with the open approach, we have to make the incisions and do all these things. And once we reach to the kidney, we have to locate the calculus. And after removing the calculus, so after even after reaching the kidneys, first we have to make the incision, the cortex portion, and then convex portion of the kidney tissue, and then we have to locate the calculus, and then we have to remove the calculus. In this phase, the interior of the kidney examined for the presence of other calculus, if there is any. We have to see completely interior portion of the kidney, and then we have to irrigate that, clean that area with the sterile fluid to wash out if there is any fragments of the calculus. And still, if we are able to find any other calculus, we have to remove that through the same incision. So even while whenever you are billing 50060, you find two stones are there, two different stones are there. Still, you are going to bill it only once, because in this procedure, doctor need to explore if there is any another calculus or fragment of the calculus while doing the nephrolithotomy with the open approach. So this is with the open approach. We do have the course for the nephrolithotomy with the laparoscopic approach, but that is for the different one. For open one, we have to fill only once, irrespective of the stones. And in some cases also, whenever doctor remove the stone, doctor also insert the drain tube into the wound and layered closure is performed then. So drainage tube placement is also included in the 50060. You don't need to build that separately. Next code we have 6570 and 75. So secondary surgical operation means surgery needs to be performed second time to remove the calculus. First it has been performed, everything was cleared out, everything was normal. But now in the patient's lifetime, surgery needs to be performed one more time for the same intent or condition. Then we are going to build 50065. Next we have complicated by the congenital condition. As it says, congenital kidney abnormalities such as ectopic kidney. Ectopic kidney means the location of kidney is not at the natural location. So if the patient have the ectopic kidney, as well as there is other condition, horseshoe kidney. So if the patient have these type of congenital abnormalities and doctor need to do much higher procedure as compared to the normal kidney, then we are going to build 50070. And in the last, we have 50075. That is Staghorn calculus. Does anyone know what is the Staghorn calculus? This is Staghorn calculus. Any answers? Any? Okay. Staghorn callus is a large stone. So basically, it's a large kidney stone which cover the renal pelvis. This is the, oh, you guys are not able to mute yourself, unmute yourself. Okay, you guys are unmute yourself or not?
Yes,
Please
ma'am.
let me
We
know if
can
you.
unmute, ma'am. We
Perfect,
can, ma'am.
perfect. Because I haven't received the answer for Staghorn, so I thought that you guys doesn't know how. Perfect. So the Staghorn calculus means it's a large kidney stone that fills the renal pelvis. This is a renal pelvis which acts as a funnel. to collect the urine from the kidney and then move through the ureters. So it will cover the renal pelvis and the callus areas. And so this is a staghorn calculus. Okay. So whenever doctor need to remove the large staghorn calculus, which cover the renal pelvis and calcis, then we are going to build 50075. Now let's move further. Next section we have nephrolithotomy with the percutaneous approach. Earlier, we studied out about the open approach. I told you from where we have to make the incision and everything. In this, we are going to build the percutaneous approach. Percutaneous means through skin. Percutaneous means through skin. So, through skin means removal of stones. We just have these two codes here for the percutaneous approach, and these two codes are based on the size of the stone. So, if it is till 2 centimeter, we are going to build 50080. If it is a complex, that is stones in the multiple location or above than 2 centimeter, we are going to build it 50081. With the percutaneous approach, we can build the fluoroscopic guidance as an additional code if the fluoroscopic guidance has been performed in conjunction with the nephrolithotomy. So this is the percutaneous approach. Earlier we studied about the open approach. Next section we have transections and the reposition of the apparent renal vessels. Aberrant means malpositioned. That means the renal vessels are not at the correct location. So in this case, transaction and reposition. So first, doctor is making the incisions and then positioning all the renal vessels during that same incision. This is a separate procedure. Separate procedure means you have to build this procedure only if there is no other major procedure performed at the same site at the same time. So if there is any other major procedure which we are going to build at the same time and at the same location, in that case, we are going to build that major procedure. We are not going to build 50010. Next, we have pilotomy with the exploration. What does pilo means? What does pilo mean? I recently told you renal pelvis is known as pilo. This renal pelvis is known as pilo. Okay. So pilotomy with exploration 50120. What does pilotomy means? This is very word to word procedure. Pilotomy.
Excisions of renal pelvis.
It's not excision, it's an incision. Incision. Okay. Excision means removing out. Incision means just making an incision over that organ. So very good, Jamil. So pilotomy means incision over the renal pelvis, and during that incision or with that incision, doctor is also exploring that kidney's internal area in cortex or convex area to verify if there is any other conditions. So pilotomy is incision in the renal pelvis area. Then we have a 50125 with drainage. Drainage means for drainage we have to place the drainage tube also. So whenever we are going to place a tube or any drainage tube, then we have to use the suffix ostomy. That means there is an opening has been created in the pilot renal pelvis so that fluid can be removed from that area. Okay, let's move further. This one, removal of calculus, pylolithotomy. Litho means stone So here the calculus has been removed. Next section we have excision. So excision means removing of that area or that organ. As currently we are studying about the kidneys procedure. So here we are talking about the removal of the kidney or the portion of the kidney. So the first code we have here 50020. In our manual, kidney referred as in renal or nephro. We does not have the kidney word in our manual. We have either renal or either nephro. The first we have renal biopsy. This is through the percutaneous approach. What does percutaneous mean?
Through skin, ma'am. Via skin.
Very good, Jamil. Rest of users or rest of the coders, are you guys able to follow me? Are you guys able to understand? Because I'm just getting the responses from the Jamil. Guys, whenever you have a doubt, you have to ask. Then only I can understand. So please let me know if you have any doubt, any questions, any queries. Just interrupt me at the same time and ask your question. Okay. So I'm moving further. So very good, Jamil. One more time. Percutaneous means through skin. So whenever doctor is removing any particular area or any particular specimen through skin, we are going to use this 50200. This is for renal. So the specimen should be the kidney specimen because we are talking about the kidney right now. And we have to build this code whenever the kidney tissue has been removed with the help of trocar or with the help of needle. If it has been removed with the help of trocar and needle, then only we are going to build the 50020. If it is performed as an open biopsy, we have to use a different code. So everyone knows about the needle. This is a syringe. So core needle biopsy, that is also known as core needle biopsy, where the normal size of syringe has been used to remove the or to take the specimen from the kidney. Trocar is a little bit. It's a trocar is also a tool. Okay, let me show you the picture. So trocar is a kind of sharp tool which has been inserted into the patient's body. Let me show you that. So these are the trocars, which is little bit. These are the trocars that has been inserted into the patient body and the specimen has been suctioned. So these are the trocars. Okay. So next we have one more thing. If the renal biopsy has been performed, a renal FNA has been performed. So specimen has been taken through the kidney itself, but that is taken through the fine needle aspiration technique. So in the fine needle aspiration technique, we have the fine needles, which is needles are little specimen are taken in the form of droplets or in the forms of very minute specimen. So whenever there is an FNA, whether it is performed on the kidney, intestine, wherever it is. So if it is a minute needles has been used, FNAs was performed, we have to use 100 series only. We are not going to use the 5 series. So even though it has been performed through the percutaneous renal specimen has been taken, but if it has been taken through the fine needle aspiration technique, let me show you the picture of the FNA's needle. FNA needle. So fine needles are very thin needles, okay, compared to the trocars and the normal needles. So you can see here, this is a core needle biopsy. This is a little bit thick compared to the FNA. And these are the trocars. With the help of vacuum techniques, we have to remove the tissue. Any questions here? Any doubts? Okay,
No,
I'm
ma'am.
going to send one. question. We have to attempt that, then only we will move further. Any other answers? Okay, let's do this question together. Okay, now let's do this question together. In our case, doctor is coming for the percutaneous needle biopsy. Patient had the complex cystic renal mass already. It has been identified preoperatively. Patient has been prepped and trapped in a sterile manner. And then sonographic examination of right flank demonstrate large cyst in the lower pole of the right kidney. So there is a large cyst in the lower pole of the right kidney. It's a needle biopsy. It's not the fine needle aspiration. So we have to rule out the option number A and option number D. Option number B and option number D. Option B and D has been ruled out because we have to use one series code only if it is a fine needle aspiration. If it's a fine needle aspiration, then only we have to use this code. If it is only needle, we are going to consider this as a core needle biopsy. For the fine needle biopsy, we should have the documentation which will tell us that this is a fine needle aspiration. So now we are left with two options, option number A and option number C. The difference between these two, 50390 and 50200. So 50200 is nice renal biopsy with the needle approach itself, and 50390, let me pull that code. So 50390 is an aspiration. Aspiration or injection of the renal cyst or pelvis by the needle. But in our case, it's not the aspiration, it's a biopsy of the specimen, renal specimen. Then we are going to use the, what should be the answer? Answer should be the C. Our code should be 50020. We are not going to use this code because this is for the aspiration. Any doubts? Any questions here? Okay, I'm moving further. So the next section we have, okay, now let's move further. So after the renal biopsy, we have a next section for the nephrectomy. So the codes for nephrectomy is based on the how much kidney has been removed. It's a partial, complete, and if there is any procedure performed on the ureters in conjunction with the kidney, as well as bladder cuff procedures. Okay, so the first one is 50220. That is a nephrectomy with a partial uretrectomy. Partial ureter has been removed in conjunction with the kidney. Any open approach. So as it is an open approach, we have to do the rev resection to reach the nephro. Okay. The next code we have 50225. Nephrectomy is complicated because patient had the previous surgery on the same session or same kidney. So if it isn't complicated, we are going to use 50225. You have to remember one thing, that the 50225, you are not going to use the modifier 22 because 22 modifier is included in this. So we are not going to use modifier 22 in conjunction with the 50225. Next term we have radical. What does radical means? We have already discussed so many times. What does radical? Any answers? Radical means whenever doctor is removing that organ as well as their adjacent lymph nodes. Okay. Next we have 50234 nephrectomy with the total uretrectomy and bladder cuff. That means these are the bladder cuff. Let's say these are the ureters, and here we have the bladder cuff. So with the conjunction with the ureters, bladder cuff has been removed. In the same session, in the same incision, then we are going to use the 50234. But if the separate incision are required to remove the kidney as well as to remove the ureters, then we are going to use the 50236. So our nephrectomy codes are based on the whether it's a partial, total, uretrectomy was performed with the same incision or the separate incisions, or any drainage tube has been placed. All these codes are by the open approach only. So these codes you have to report if a kidney has been removed with the open approach, then only you have to fill this. Next section we have ablation. Ablation means to remove something, to ablate something with the external energies. External energies we can use here cryosurgery, laser, thermal energies. Then we have to build the ablation. Next we have excision or unroofing. So let's say if there is a cyst and doctor is just unroofing that cyst, then we are going to use 50280. Excision of perinephric cyst. Perinephric means area, this is the area. The outer wall of the kidney is a perinephric area. Then we have a renal transplantation. Renal transplantation. So any transplantation, not just renal, whether it's a liver transplantation, renal transplantation, kidney transplantation, any transplantation. Any transplantation requires three components, okay? Three components. The first one is cadaver donor work or the living donor work. First, we have to identify whether it's a cadaver donor nephrectomy or the living donor nephrectomy, unilateral or bilateral. So for the cadaver, that means the other user who is donating the kidney is not living at the moment. He already died, and we are removing the kidney for the donor purposes. That is cadaver donor nephrectomy, unilateral or bilateral. So donor nephrectomy includes harvesting the graft. Harvesting means removing the graft as well as preserving the graft. Preserving means storing the graft at a particular location so that we can implant the graft in the next sitting or at the same time, and then moving here and there, graft moving here and there. So usually we are doing the cold preservation where we have to keep the graft into the fridge or in the cold. If it is a living donor, it does not have the option for unilateral and bilateral in the living donor, because from the living donor we are allowed to use only one kidney. We are not going to remove the two kidneys at the same time. So for the cadaver donor, we have an option for unilateral and bilateral, but for the living donor, it does not have the option for the unilateral and the bilateral. Same things are included here. Harvesting of the graft and the cold preservation is already included here, and we are not going to build that separately. Next things we have backbench work. So the first we have to prepare, we have to harvest the graft, then we have to preserve that graft. The second step is backbench preparation. So backbench preparation includes dissection and removal of perinephric fats. Perinephric fats means if there is any attached fats at the outside of the kidney, then we have to remove that before transplantation. Not just perinephric graft, we have to see if there is any retroperitoneal attachments. We have to excise those. We have to remove those. If there is a adrenal glands, we have to remove that. We have to prepare the uterus, renal veins, or any adjacent arteries, any adjacent vessels. So that includes the backbench procedure, and we have to build these procedures with the help of the backbench procedure code only. So the standard backbench preparation of the living donor renal graft, whether it's an open or the laparoscopic approach, we have two types. And prior to transplant, we have to dissect them, remove the perinephric fat, we have to prepare the vessels, and then we have to ligate them. So this is the backbench procedures. Next, we have recipient renal allotransplantation. Allotransplantation means now kidney has been harvested, preserved. We have already removed the perinephric fats and clear them out. So now we just have the graft. Now we have to place them. So we have to place them, and we have these two codes for the allotransplantation. These two codes are based on the whether we have to remove the kidney now or we don't need to remove the kidney. If we have to remove the kidney, we are going to build the 365, the already placed kidney. If it does not need to remove the kidney, then our code should be 50360. Remember, these all procedures are by the open approach. If it is done by the laparoscopic approach, we have to follow the different code series there. So 50300 is donor nephrectomy. The first one is cadaver. We have option unilateral and bilateral. And next one is open from the living donor. Then we have a backbench procedures. I've already told you these codes are based on the open and the laparoscopic approach. This one is cadaver donor. This one is living donor. Next, we have backbench reconstruction of the cadaver living donor. So we have preparing the allograft prior to the transplantation, where we are doing the venous anastomosis or the arterial anastomosis. Venous anastomosis, that means both veins has been anastomosis with each other. Next, we have 50328 arterial anastomosis. Arteries has been combined together. Then ureteral anastomosis. It has been joined with the ureterals. 340 is recipient nephrectomy. That means where we are going to place the kidney, we are removing the kidney first from the recipient area that we are going to build with the 50340. Then we have 360 and 365. So at the same time, when we are removing the kidney, we are doing the allotransplantation. We are placing the kidneys. Then we have to build the 50365. If we are just placing the kidney and we have already done the nephrectomy in the earlier phases, then we have to build the 50360. So these two codes are based on the transplantation, whether it has been done at the same time of the nephrectomy or whether it has been performed prior to the transplantation. Now I'm moving to the next section. introduction. I'm going to send one question to you guys. Try to attempt that question, then we will move further. Okay. Two minutes more. Please try to solve this question. Okay. Now let's discuss this question together. So in our case, doctor is doing renal autotransplantation with the extracorporeal surgery, and he reimplantation of a kidney. And doctor also did the partial nephrectomy. So the correct answer is C. Jamil already provided the correct answer, so I'm not going to discuss this question. Does any one of you have any doubt here? Or shall we proceed further? Because none of you gave me the incorrect answer.
Yes, ma'am. Can you please discuss it?
Okay. Did you have any options that you have already ruled out? Did you try to attempt this question?
Yes, ma'am. I
Because
tried, but
Mhm. Yes, tell me, but because what
I'm
I
not.
feel that none of you guys are try to attempting that. That's the only reason I don't want to discuss this. Okay, now let's proceed further. So the first option we have here 50380, 34 and 343. So we will see what is the difference between 340, 43 and 80. Okay, 50340. So 380 is in renal autotransplantation with a reimplantation of kidney. It seems correct because this is what happened in our procedure. It's a renal autotransplantation, and reimplantation. So 380 seems to be correct. But we do have the other options also, 340 and 43. So 50543 is so 50543 is a partial nephrectomy, but this is with the laparoscopic approach. In our case, laparoscope were not used, so we are not going to use this code. So we have to rule out 50543. This option has been ruled out. Now we're left with these two options. Let's see the difference between 380 and 340. So 50340 is a recipient nephrectomy, and this is a separate procedure. Recipient nephrectomy means the complete kidney has been removed, but in our case, only partial kidney has. Can anyone of you tell me, do we have to use recipient nephrectomy here, or do we have to build that other code, partial nephrectomy one? Can we consider recipient nephrectomy equivalent to the partial nephrectomy?
No, ma'am.
Yes, we cannot, because partial means removing the half kidney, whereas recipient nephrectomy means removing full patient's kidney, where we have to place the kidney. Okay, so we have to rule out this one too. Now, the difference between option C and D is modifier 59 and 51. What is the difference between modifier 51 and 59? Any one of you? What is the difference between these two? Okay. 51 is multiple procedures, where 59 means distinct procedure. We have to use 59 procedure, 51 modifier only if we have to represent that these two performed at the different sites, different areas, and these are not the component of each other. Then only we have to build the modifier 59. But in our case, we are going to use the modifier 51. Why? Because these two procedures performed through the same incision at the same time, but so we are going to use the modifier 50. Gauri, any question here?
No,
Who is
ma'am.
asking? Clear now? That answer should be C instead of anything else.
Yes,
Yes,
ma'am.
ma'am.
Actually,
Understood.
ma'am,
Tell me.
from
Yes.
where we can get the idea of modifier, because actually in 50240 I was not able to get the modifier. Means not able to connect.
What if? Okay, not able to connect. So let me do one thing. Let me open. Page number is 448. 44. Okay, this is the modifier 51. Kashish, do one thing. Just read the description of the modifier 51. Just read it out. Okay?
Yes, ma'am. I'm done, ma'am.
Okay. Now read the description of the modifier 59. Done with reading, Kashish?
Yes, ma'am, I got it.
Okay, now tell me what is the difference between these two?
Modifier 51 is for multiple procedures, but 59 is for distinct procedures. Um,
Okay, what else? How we have identified that this should not be a distinct instead of the this should be the multiple? Why have decided this?
because here it is a renal transplantation, then it is again it is reimplantation at the same site, but multiple procedures are done.
Exactly, it's a multiple procedure because it is with the same incision and these are not the component of each other. So that's the only reason we are not going to build the 59 modifier. Okay.
Yes, ma'am. Thank you.
Thanks. Now let's move further. So it's a okay. The next section we have introduction. Introduction codes describe aspiration. That means aspirating any fluid. Injecting means inserting something patient's body, and the installation also. We do have the code in this section for the removal and the replacement of the urethral stents. And we have two types of stents: internally dwelling stents, externally accessible transnephritic stents. So, the difference between internally dwelling as well as the externally accessible stents: in the internally dwelling catheter inserted through the inside the body, let's say catheter inserted through the bladder, then ureters, then kidney. Whereas externally accessible are the non-invasive or less invasive, not the non-invasive, it's a less invasive procedures where the stunt or the stunt has been placed at the skin level externally. that is externally accessible stents. Okay, so we have two types of stents: internally dwelling and the external. Internally dwelling means inserted through the internal of the ureter. So the removal, we have these two codes. This one removal and replacement, and this one just a removal. Next we have removal and the replacement via transurethral approach. Then this one internally via. Can any of you tell me the difference between 385 and 386? It's the same difference that this is a replacement, this is a removal with the transurethral approach. Then we have the external accessible stents. So first we have a removal and the replacement. Then we have removal of nephrostomy tube. Then there is other introduction and injections. So aspiration, instillation, dilation. These codes comes into this introduction section. So I'm not going through word to word with the each code because these all are the same type of. So I'm moving further. Okay, the next section we have here repair. Repair means repair of an organ, that is kidney. We are talking about the kidney only. To treat injury, disease, any congenital abnormalities, any structures means stenosis or the any obstructions. So that is repair. And the suffix we can use for repair is orafi or rafi. This is a suffix for the repair. Exi. Exi is another suffix for repair. So these are the suffix for the repair as well as the plastic. Plastic. So the first code is 50040. Pyloplasty. Pyloplasty means plastic repair of the renal pelvis. This is the pylo means renal pelvis. Then we have 50405, complicated due to the any congenital kidney abnormality such as horseshoe, ectopic kidney, or solitary kidney. So that is 50405. Okay, next procedure is symphysiotomy. Symphysiotomy majorly performed after the pyloplasty to improve the drainage so that there should not be a blockage. Then we are going to do the symphysiotomy for the horseshoe kidney. So he's just removing the horseshoe connections. That is 50540. Next we have laparoscopy. Laparoscopy surgery. Next, we have a laparoscopic. Can any one of you tell me the laparoscopic approach? What we have to do in the laparoscopic approach? What we have to do in the laparoscopic approach?
Ma'am, incisions.
And what we have to do in the open approach?
Uh,
This is not acceptable that none of you is able to answer the basic difference between the laparoscopic and open approach. We have already discussed about three approaches. First, open approach. Second, laparoscopy approach. Third, endoscopy approach. And the fourth one, percutaneous approach. Percutaneous approach. So in the
ma'am,
open approach, yes,
open approach. Uh, Open approach means, ma'am, like massive incisions, like large incision.
exactly. In the open approach, the whole procedure is done with the incision. We need to make the incision a large incision to reach out to that organ where the procedure is going to perform. The next point we have laparoscopy. Lapro means abdominal cavity. Lapro means abdominal cavity. So whenever scope has been inserted through the abdominal cavity with the help of portals or ports, then we are going to call it as a laparoscopic approach. In the laparoscopic approach, we have to mark incision in the mm. So in the open approach, we have to mark the incision in the cm. But in the laparoscopic approach, we have to do the incision in the mm. Let me show you the picture of the laparoscopic approach. Laparoscopy. Laparoscopy. So these are the laparoscopic approach. You can see here. This is abdominal cavity. Instrument has been inserted. Then the stomach has been inflated with the CO2. And then the procedure is performed with the help of these tools as well as the monitor. In the monitor. So what happens? This is a tool. In this tool, the camera has been inserted. Zoom this out. So you can see this is a tool. Here, doctor need to insert the camera and inflate it. And with the tools, with the other tools, doctor is able to perform the other procedures. So this is a tool, this is a camera. With the help of camera, we are able to see here that where we are doing the procedure, and with the surgical instruments, we are doing the procedure. So laparoscope, that means inserting the scope in the lapro. Lapro means abdominal cavity. Difference between laparoscopy and open is clear to everyone?
Yes, ma'am.
Yes, ma'am.
Okay. Next, we have the endoscopy approach. Endoscopy approach we had discussed in the last session. Now you have to tell me what is the difference between endoscopy and the percutaneous approach. We had discussed the endoscopic approach in the last session. We talked about the EGD, colonoscopy.
Ma'am, endoscopy means it's a procedure where like tube inserted into the mouth or through nose. So like uh,
Good. Yes, you
small
are going correct.
incisions will be done, ma'am.
And what about the percutaneous?
Percutaneous means through skin.
Exactly. Percutaneous means through skin. So endoscopy scope has been inserted through the natural orifice, whereas percutaneous means the procedure has been performed through skin without incision. Without incision. So these are the few approaches to reach to the organ. So the laparoscopy. This is a laparoscopic approach means laparoscope has been used to treat the or repair the kidney. So the first is laparoscopic surgical ablation of renal cyst. So it seems that only the renal cyst has been ablated. Then we have ablation of renal mass. So all these procedures are the laparoscopic procedures. These all are the laparoscopic procedures. So I'm just skipping this out and moving to the next topic. This one, lithotripsy. Lithotripsy means it's basically a litho means stone and tripsy means crushing of the calculus. So it's a crushing of the calculus where we have to use the extracorporeal. Extracorporeal means outside the body. So extracorporeal outside the body. So in this procedure, extracorporeal shock wave has been inserted. Oh, sorry. Extracorporeal shock waves are focused on the stones and then we have to administer into the controlled manner so that these are the extracorporeal shock waves. Okay. We have to insert that in a manner that only stones can crush them. We may need to use the local anesthesia or the general anesthesia. We have a two type of extracorporeal. The patient position in a special chair so that we can do this procedure and reach out to the calculi. So this is a lithotripsy. We just have these code for the lithotripsy. Where it is lithotripsy 50590. We just have the one code for the lithotripsy. Next section, ureter. Codes begin from series 50600 to 50980. Incision in biopsy. So the first is incision. We already know what the incision means. So I'm going directly to the code. 50600 ureterotomy with exploration. 605 with the insertion of indwelling stent. 50606 is an add-on code for endoluminal biopsy of ureter or renal pelvis, non-endoscopic, including imaging guidance. So whenever doctor is doing any endoluminal biopsy of the ureter, not outside the endoluminal biopsy of the ureter or the renal pelvis, without endoscopic approach, Then we are going to use the 50606 in conjunction with the other main procedure. So this is an add-on code. And you have to remember one more thing, you cannot use modifier 51 with add-on code. Other Next we have ureterolithotomy, removing of ureter stone, 50610, 620 and 630. So 610 is upper one third of ureter, 620 is middle third, and 630 is lower one third. So this is based on the size and the way the stunt we are going to place. Next section we have excision. Excision, uretrectotomies. So doctor is just removing the ureter completely. This usually performed for the ureteral cancers. And whenever you are going to build the uretrectomy, the 50650, this is a separate procedure. You have to make sure that you are not going to build any other major procedure. So whenever there is a separate procedure means we have to build this procedure only if this procedure is going to perform. If we have any other procedure performed at the same time on the ureter, then we have 50660. Okay, let's move to the introduction section then. So it's the same as a normal procedure. So in the introduction section, we are getting the codes for the injection, instillation, as well as the aspiration. We do have a code for a manometric studies. Manometric studies means checking the pressure of that area, that is manometric studies. Five zero six eight four injection procedure for the ureterography. So these are the very normal procedure. We does not have any specific guideline on these procedures, so I'm skipping it out. Okay. Give me a second. Let me see if I can find any specific question from the ureter section so that we can do the practice. Please try to solve this question. Any Jamil, Vaishnavi, Gauri, any answers?
Ma'am, your voice is not audible.
Sorry, I was talking in mute. So let me try it one more time, huh? So in this case, patient is coming to remove the stones from the both kidney. Patient is taken into the lithotripsy unit and placed on the lithotripsy table in the supine position. And then after the anesthesia, patient received 3500 shock waves. That means extracorporeal shock waves has been used to remove the kidney, to remove the stones. So this is a lithotripsy procedure. For the lithotripsy, we are going to use 50590. So the answer should be 50590. Clear?
Yes, ma'am.
Okay. So now I'm going to start with the repair section under the ureter. So repair codes 50705, 706, and so on. These are the add-on codes basically. So ureteral repair often performed for stricture and inflammatory disease, repositioning, reconnection, and anastomosis. So these are the basic procedures which we can perform with the repair of ureters. So the first code is uretroplasty 50700. So it's a plastic operation on the ureter. Based on the name itself, you can understand that it's a uretroplasty. Then we have 50705, ureteral embolization or occlusion. So these two codes, 50705 and 706, are describing the embolization and the balloon dilation. Embolization and occlusion or balloon dilation of the ureter, where the doctor is using the non-endoscopic imaging guidance. So these two codes we have to use in conjunction with the other main procedure to represent the embolization or the dilation of the ureters. So next section we have here. This is ureterolysis 50715. So lysis means releasing the ureters. This is for without reposition for the retroperitoneal fibrosis. So these codes are based on the disease. This was ovarian vein syndrome. This is reanastomosis. Revision of reanastomosis. Anastomosis means joining two ends. Joining two ends means anastomosis. I'm looking if we can find any specific guideline here which we can discuss today. 517. So it's a 50810. 50810 is ureterosigmoidostomy. Ureterosigmoidostomy means combining ureter and sigmoid together. When we are combining ureter and sigmoid together and creating an, that means 50810. Next, we have a ureterocolon conduit. Next, we have after the conduit, the same procedures with the laparoscopic approach. These are the same procedures with the laparoscopic. This is a so you have to look for the approach. We have the endoscopic section also in the ureter. Endoscopy means scope has been inserted through the natural orifice to see for the diagnostic purpose or to see what's happening in the inside the body. Correlation, I'm seeing if we can find something. These are the removal. Excision, as we can study. Oh, now let's discuss about the urodynamics. This is an important topic we can discuss. So urodynamic means anyone can tell me what is urodynamics? What we can represent with the urodynamics? Urodynamics, anything. So urodynamic codes 51275 to 51798. Here we have. These codes have the professional and the technical components. So we can build these codes with the 26 modifier and with the TC modifier. TC means technical component and 26 means professional component. So if we are going to build these codes without modifier, that means it's a global procedure. If it is without modifier, that means it is without modifier means global. You are building the 26 professional component as well as you are building the technical component. So in the urodynamics studies, we have to access the bladder, urethra, or any associated nerves and muscles to see whether it's performing it or functioning it well or not, appropriately functioning or not. These studies are usually performed for the incontinence, urinary tract infections, voiding issues. Voiding issues means that patient is not able to empty their bladder. So these are the voiding issues and any urinary tract infections. So these studies, all codes are for the studies. Okay, these are not the procedures; these are the studies. We are going to get a particular results after these studies. So in these studies, we have the CMG. CMG stands for cystomatogram. Yes, Let me pull that code first. Here it is. Cystomatogram. This study measures how much fluid is in the bladder, which bladder can hold appropriately. So the cyst means bladder. This is bladder. This study will help us to understand how much fluid bladder hold. So it will review the pressure, that how much pressure build up inside the bladder can patient easily manage. And what we have to do here, we have to place the spinal manometers or the catheters into the bladder that contain the pressure measuring device such as manometers. So these are the pressure measuring devices. Manometers are the pressure measuring device. And the another catheter may be placed in the rectum or the vagina to see if there is any intra-abdominal pressures also. As the bladder slowly fills with the warm water, which is a urine, the manometer records bladder pressure. What is the bladder pressure now? If the bladder contracts suddenly while being filled, like it has been not completely filled, it's being filled. That means it's a dropping. We are getting the fluid into the bladder, but it's not completely filled. If the bladder contracts means there is a urge of voiding. Then manometer records the leakage because it's we have the device that will tell us that how much pressure bladder can hold. If there is a leakage, then it will represent that there is a leakage and we cannot hold anything. So when the pressure bladder is filled and we are able to see the pressure that how much patient is able to hold, then we can ask our patient to please go ahead and void the urine. So basically, a CMG is a two type of procedures, complex and simple. In the complex, we have used our specific calibrated equipments, whereas in the simple, the normal catheter has been used, the manometer has been used to identify the pressure of the bladder. So in 51728, with voiding pressure studies, bladder voiding, like here we are reviewing the bladder pressure, that how much pressure bladder can handle. But in the 51728, after voiding it, we have to study that bladder voiding pressure. What is a bladder voiding pressure? In that case, we have to use 51798. So, uh, sorry, not 98, it's a 28. So the code 51729 we have to use when the intra-abdominal voiding pressure study is performed with CMG. Then we have to use 29. Next we have 51797. 51797 we have to bill when voiding pressure studies intra-abdominal. These are the voiding pressure study for the bladder. This one is intra-abdominal. Next we have 51736 to 51741. These are the uroflowmetries. Uroflowmetry, also known as uroflow. What it will do? It will measure the amount of urine and the flow rate. So uroflowmetry will measure the amount of urine as well as the flow of urine. So next studies we have 51784. Electromyography studies of anal or urethral sphincter, which is other than needle. We do have a code for the needle also. So this is needle. The previous one we have for the other than needle. So 51792 stimulus evoked response, also known as SER. So it will measure the reflex of latency. That what is the latency time when we will give any reflex there, how much latent the responses are. So that way we're going to represent with the 51792. Then we have 51798, measurement of post voiding residual urine or bladder capacity by ultrasound. So with 51798, this is a bladder scan ultrasound. Bladder scan and ultrasound is used to assess post void urinary bladder retention if there is. So post void means after emptying the bladder, it will see if there is any retained fluid in the bladder. So it will represent that if there is any post voidal residual fluid or not. Then we have next section we have repair. In the repair, just give me a second. Okay. So in the repair section, we have a cystoplasty or cystourethroplasty. Cysto means bladder, so it's a repair of bladder, repair of bladder and urethra. So vesicourethropexy or vesicourethropexy and it's a normal urethropexy also. So the code starts from here. In this procedure, doctor is with or without resection of posterior vesical neck. So here these are procedure are for the posterior one. We do have a series for the interior. This one is a posterior. Now I'm pulling the next one. Look, these are for the interior. So 51840 to 841. Simple and complicated. So 51841 we have to bill to report if there is any secondary repair. Secondary repair or any increased time which is due to the complications of the procedures, then also we are okay to use the 51841. Next we have 51845. This describes an abdominal vaginal vesical neck suspension. As its name says, so this is a female specific code because here we have the female specific organ, that is vagina. So this code we can use for the female only. The STEMI technique is performed vaginally through the small incision which is above the pubic bone, and then suture is used to suspend the tissue which is next to the urethra on each of the sides. So each urethra sides we have to suture them out, and then we have to perform the cystoscopy to ensure there is no issues or there is no urethra and bladder has been injured or there is no iatrogenic injuries during the procedures. Okay, now let's see what next we have here. Next section we have the laparoscopy. So we have to wrap up the session now. And from next session we will start with the 51990. Okay, so I'm mentioning in a mic group. From next session, we have to start with the CPT. What was the CPT? That is 51990, I think. Yeah, 51990. In the next session, we will start with the CPT 51990. Now let's wrap up the session. Thanks, everyone.
Thank you, ma'am.
Thanks for your time.